To prevent injuries this season, the club will undertake a screening of their players to determine if there are any risk factors for specific injuries. This presentation will discuss if a static assessment of limited dorsiflexion or an apparent ankle equinus is a risk factor for Achilles tendinopathy. The purpose will be to implement preventative strategies or to simply cut them from the team before these risk factors result in injury. Before we can start the screening process, we will look at highly rated journal articles which will either support or disprove our theory. Before we begin our research, an overview of the pathology and its incidence should be investigated. Firstly, the Achilles tendon is the combination of the gastrocnemius and soleus into a tendon that attaches to the posterior surface of the calcaneus. The Achilles tendinopathy is seen as an overuse injury with rapid increases in training loads being a primary risk factor and occurs at either the insertion on the posterior aspect of the calcaneus or the midpoint of the tendon, which is 3 to 6 cm proximal to the insertion. The pathology is caused by an interruption of the equilibrium of damage equaling repair. As the Achilles tendon is subject to increased forces or repetitive forces over a sustained period of time, the cross-linked collagen fibers begin to fail. This is subsequently tracked by the repair of the tendon. When there is an imbalance to the equilibrium of tearing and repairing not being equal, that is when the Achilles tendon becomes symptomatic. An ankle equinus, or a limited range of dorsiflexion motion, less than 11.5 degrees, is suggested to place more tension on the Achilles tendon due to the decreased range of motion, and therefore increases the chance of developing Achilles tendinopathy. With a consensus of multiple studies, we found the rate of Achilles tendon rupture and tendinopathy reported to be annually 7 to 9% in runners. The condition affects both sedentary and active groups. The mean age is between 30 and 50 years, and there is also a rise in the prevalence with increasing age. We found that males are more prone to the pathology than females, however more research needs to be done in this particular area. To undertake our research, we first developed a PICO question to address the etiology of Achilles tendinopathy. We decided that the population or problem should be those with Achilles tendinopathy. An intervention and co-intervention were deemed unnecessary as we were only interested with the etiology at this point in time. And our outcome was those with Achilles tendinopathy also had to have either a limited dorsiflexion or an ankle equinus, which then led us to the overall question. Is ankle equinus or limited dorsiflexion a risk factor for the development of Achilles tendinopathy?
In conducting our search strategy, a beginning point of call was determining the appropriate search terms required for an accurate and high-achieving search. This involved exploiting our starting terms of Achilles tendinopathy, equinus, and limited dorsiflexion to and/or that of tendosynovitis, tendinitis, and all the variations of the word limit and any associated synonyms, also including equinus, limited dorsiflexion, and increased range of motion. In using variations, we hope to collect all potentially appropriate articles. To ensure high-level credible research is found, the use of La Trobe Library and Google Scholar search engines, including top databases such as Medline, were required. Further using these databases, advanced search techniques are applied. This include multi-field searches involving truncation and wildcard techniques such as asterisk, question mark, and or and not in capital letters. Search terms excluded using the capital NOT of Boolean logic for systemic disease and dynamic measurements. This is shown in the example provided. In narrowing our search and moulding it to the inquiry population, we have used refining techniques specifying in the following examples: language, English; abstract for specification; humans; publications in the past 10 years. The use of age group, gender, and athlete refining techniques eliminated too many options but were however appropriate in the Kaufman study. In completing the study, we successfully identified 2 Level 2 prospective cohort studies on the NHMRC table. These are intrinsic risk factors for the development of Achilles tendon overuse injury, a prospective study by Mayu, the effect of foot structure and range of motion and musculoskeletal overuse injuries by Kaufman. We critically appraise the evidence using the CASP Critical Appraisal Skills Program approach. There are 3 steps in the CASP approach. Step 1, is the study valid? Which aims to answer the following: was the issue addressed? Was it recruited in an acceptable way? Was the exposure and outcomes accurately measured to minimize bias? Have the authors identified all important confounding factors and taken these into account in the study design? Was the follow-up complete and long enough? In the study by Kaufman and colleagues, we found that all the criteria was met except to identify the important confounding factors, and they have been taken into account for the study design. The study by Mayu and colleagues was also found to have not identified or taken the confounding factors into account. Step 2 refers to the results. The results of the study show that a decreased dorsiflexion with knee extended leads to Achilles tendinopathy. The results were measured using a 95% confidence interval, and we found the results believable. Step 3 refers to the usefulness of the results. We found that we could apply these results to our study, although it didn't fit with the other available evidence. The implications of the study is that Achilles tendinopathy in active adults may be due to tight gastrocnemius muscles rather than decreased dorsiflexion.
For the results of the study of Kaufman and colleagues article, it stated 404 SEAL candidates had their ankle range of motion, degree of dorsiflexion measured, with their knee extended, and 402 had their ankle range of motion measured with their knee flexed. Results are presented as risk ratio point estimates, with 95% confidence intervals. As seen from the above data, having a normal ankle range of motion, knee extended or flexed, does not increase the risk of developing Achilles tendinopathy. The risk ratio is 1.00 and the p-value is greater than 0.05. Although having a flexible ankle range of motion in both knee extended and flexed positions, they were reported to be associated with an increased risk factor of 2.57 and 1.32 times of developing Achilles tendinopathy respectively. They were not statistically significant. With the knee extended, the risk ratio was 2.57 with a 95% confidence interval of 0.70 to 9.49 and the p-value of greater than 0.05. With the knee flex, the risk ratio was 1.32 with a 95% confidence interval of 0.47 to 3.71 with a p-value of greater than 0.05. Having a limited ankle range of motion in the knee flex position is also not statistically significant for an increased risk of developing Achilles tendinopathy, with the risk ratio being 1.08 with a 95% confidence interval of 0.36 to 3.26 and a p-value of greater than 0.05. However, having a limited ankle range of motion when the knee is extended, statistically, this significantly increases the risk of developing Achilles tendinopathy by 3.57, with the risk ratio being 3.57, a 95% confidence interval of 1.01 to 12.68, and a p-value less than 0.05.
The results of the study showed no significant differences, and that an increased dorsiflexion led to Achilles tendinopathy. The results were measured using a 95% confidence interval, and we found the results believable. Step 3 refers to the usefulness of the results. We found that we could apply these results to our study, although it didn't fit with the other available evidence. The implications of the study is that Achilles tendinopathy in young active adults may be associated with predisposed increased range of motion in ankle dorsiflexion.
The results of the study by Mayo and colleagues differ from the Kaufman study. 69 officer cadets had their ankle range of motion, with the degree of dorsiflexion, measured with their knee flexed and extended before undergoing 6 weeks military training. 10 of the 69 sustained Achilles tendinopathy after the training. The results, or the ratio scale, are presented as descriptive statistics, the population mean and the standard deviation. Inferential statistics between the two groups, injured and uninjured, were computed using either the student t-test or the Mann-Whitney U-test. As seen from the above data, there is no statistically significant differences between the groups regardless of their ankle range of motion with either knee flexed or extended, which is a p-value greater than 0.05. Hence, there was no difference in ankle range of motion between the injured and uninjured groups. However, subjects who acquired Achilles tendinopathy seem to have a more flexible ankle range of motion for the right passive foot with the knee extended, having a mean of 15.2 and a standard deviation of 5.35, as compared to those who did not acquire it. They had a mean of 12.95 and a standard deviation of 5.39. This observation, however, is not statistically significant, although it was close to it, with a p-value of 0.76. And in order to apply these studies to our screening of players, we need to discuss which article we use to either support or disprove our theory, as unfortunately the articles are not in agreement. The Kaufman study found that a reduced dorsiflexion range of motion with the knee extended is associated with Achilles tendinopathy, whereas the Mayo study found that there is no statistical differences of dorsiflexion range of motion with the knee extended for both groups, but the Achilles tendinopathy group appeared to have a higher dorsiflexion range of motion at the beginning of the military training. As we found 2 high-level studies that have opposing results, we graded our research evidence as conflicting and will not apply them to our study. We found that there is not enough evidence to support a limited dorsiflexion or ankle equinus as being a risk factor for the development of Achilles tendinopathy.